this week on the BackTable podcast.
I think you talk to any rep as well and anybody outside, right? So the people that interact with multiple specialties, you talk to somebody who does endovascular work, they generally say that they like to work with IRs over VS and IC, not necessarily because of, we all have differences in personality, but I think that's our strength is we're collaborative, we are friends, we do really well with our cheerleading, like you said. And so, the community is great and I'm glad we all chose it. So, and this is part of it as well.
This is Mike Barraza, returning as your host. I'm joined by my good friends, Sabeen Dhand and Quinn Meisinger. We're going to talk about the change in the ABR exams and talk about IR jobs in general. Guys, it's been a long time. It's been a whole week since I saw you at SYR. I'm glad to see you guys are well.
We all survived Nashville.
Nashville. Just a reminder, Sabeen is at Lake in Los Angeles. Did I say that right?
Yeah. Nice job.
And
nice
Quinn is
job.
at UCSD in San Diego. I'm in Baton Rouge, Louisiana.
Have you heard of UCSD before, Mike?
I heard of it once on the internet.
Yeah. I feel like after Zach Berman did about 9 different shows, I think UCSD is leading the amount of shows done.
It's a hot spot for Penn grads. You got
Yep.
you and my guy Jonas Redmond.
Rupal Parikh as well.
We have a handful of listeners who are trainees, and I really like UCSD. Could you tell the listeners a little bit about what UCSD's training program is like? You have a pretty cool practice set up for yourself as it is.
Yeah, so I've been the program director now about 6-7 years here at UCSD. So I run all the IR residencies, the independent and the integrated, and we can get a little bit touch on those differences later on. But so from a UCSD standpoint, number one is we're in San Diego, so I do not have a hard time recruiting. So I'll say it's pretty easy to recruit the best and the brightest when you live in San Diego. So people want to be here, including Dr. Fritz as well, moving out here recently.
That's
so,
true.
I'd say that our program is one of the most well-rounded in procedural experience. And then also we have like 4 or 5 different sites for trainees to rotate at, including a Kaiser. We also have our university, VA, and then we have a private practice, and including the Navy, the active duty Navy hospital in town as well. So the residents get to go through all of them.
Wow.
Actually, and I forgot a pediatric hospital as well. So the residents get a ton of different exposure to both the faculty, but also just the different patient populations. And, ever since Sean Tutton joined us probably 3 or 4 years ago, kind of early pandemic, we've really exploded our musculoskeletal interventions as well. So
I loved meeting that guy at SIR. I met him for the first time. You introduced me, and the first thing he said to me is like, "What is the biggest challenge in your practice?" I was like,
"Yep,
great question."
Yep.
And I had to be honest. I was like, it's one of the challenges, just being too good.
Yep. He's one of these people that can connect to anybody, and he has always the most pointed questions. So yeah, I learned that early on when he joined.
Yeah, he's a great guy. And I'm sure, your MSK intervention division just blew up then, I'm sure.
Yeah, well, we have a co-resident of mine who's a few years behind me is Anthony Tadros, and he kind of started it when he joined in like 2017, 2018. And then once Sean joined, and Chris Friend is another musculoskeletal interventionalist in our group, those guys are all pretty advanced and pretty skilled, so it makes it easy. Sometimes I get cases booked that I've never done before, like an Empire block, and I have to Google it or text them and say, I guess I'm doing this today. Yeah, YouTube or BackTable.
Yeah,
so
man, I like it.
Just blew right past my great joke. Anyway, let's keep going.
I think a lot of that's going to happen today. For those just listening to audio, we all have a glass of wine or beer in our hand right now, just looking forward to hanging out with friends on this BackTable episode. So look, all these changes happened after I graduated and after I was done as an IR, just traditional fellow. And then I went to private practice, so I kind of just shut my brain off on all these new pathways. So Quinn, can you tell me, like, what the hell is ESIR? What is independent? What is integrated? Who is an IR fellow? Like, I don't get it.
Are there IR fellows?
Are there IR fellows? Yeah, nice. in a sense. So, all 3 of us are the traditional model of doing a diagnostic or basically a radiology residency and then doing a fellowship. And, Mike and I actually being co-fellows at Penn. That was our year as a fellowship is when they started really instituting the integrated residency. So this has been something that's been in the works for quite some time, led by Vicky Marks and John Kaufman, I think, from kind of the origins and Jim Spies. And so the goal was to get some sort of, more standardized training and a little bit in an integrated residency to kind of parallel both vascular surgery, cardiothoracic surgery, so we're a surgical subspecialty at this point with regards to how our training is and how we need to make sure we have specific case logs and we have to have specific exposure to cases, and then also including the complications as well documented so that you know how to manage pre and post complications. So I think the integrated residency was kind of what all of us were envisioning. And so during the period of time as we were instituting the integrated residency and we started matching, also and then allowing residents who are currently in programs to transition into program from the diagnostic residency into the integrated interventional radiology residency, that allowed it to fill up. But what the kind of the forefathers of the integrated residency were trying to do is to figure out how we keep the pipeline alive during the transition from fellowship to a residency and how we keep the workforce stable, right? So if we're moving away from fellows and then we're starting the integrated. So the fellowship was eventually phased out, and that was replaced with kind of two different ways, and that's the early specialization in IR, and that's a diagnostic program. So most of us that were really excited about IR and, diagnostic training in our radiology residency, we usually did our fourth year mostly in IR so that we were prepared to go into interventional fellowship. And almost all of us probably think 2 years of dedicated IR procedural training is needed in order to make yourself prepared for a job. And so a lot of us saw that wasn't formalized. It was really difficult, I think, just to go to fellowship and do 1 year of procedures and then feel like you're adequately trained coming out of training. So that allowed both a pathway for the diagnostic residents to get more procedural training, and then they can transition and do this thing called the independent year. And I'd say probably across the country, almost every hospital system still calls them fellows, even though they're technically residents in the eyes of the ACGME. However, the NRMP, so the match process, likes to make it super complicated and call them a radiology fellowship. So there's quite a lot of heterogeneous nomenclature for our last year of training. But for our purposes, it's independent residency. So residents that go through ESIR will do a 1 year independent. And then those residents who go through DR and don't get an ESIR position, because not all diagnostic programs have an ESIR program, and that's the early specialization IR. And then they have to do then a 2 year independent fellowship. So the goal is to really have 96 weeks of dedicated IR training coming out of.
I don't think I had that much. I didn't have that.
I still haven't had that much.
Yeah, I'm still in training.
The ESIR though, like when do they decide? Like when do you match into that? Like, is this something, you've been in diagnostic residency for a couple of years and it's like, this is boring and, you want to go into IR. Do you decide it then, or is this something you decide early on?
Yeah, so whenever I counsel somebody picking radiology as a field, I say, okay, how gung-ho are you on IR? And generally, I want to direct them to the integrated residencies. The people that are a little unsure or they really want to test out some things, I say you should probably go to a diagnostic program with ESIR so that you have the options. But generally, most programs will then have you transition into ESIR program usually in the second year of residency. Our program has 2 positions. So if we have, let's say, 3 or 4 people interested in a diagnostic class, which is rare, it's only happened to me once where we've had more than 2, then you basically have to decide who gets the ESIR designation and position.
Can the other people apply elsewhere?
No, you can't apply outside. So your ESIR is only at the institution you're at.
Okay.
Yeah. So ESIR is within the diagnostic residency. I mean, from the perspective of most of us in the IR program directors, and we had a pretty long discussion in Nashville last week at SIR, was, what is the utility of this? And it's obviously a heterogeneous training atmosphere. So, you could go to a program that doesn't have a lot of IR faculty or a nice wide range of procedures. And so your ESIR can be very limited. So that's a little bit of a limitation of that as well. But for me, I still like it because it allows residents to get in the IR if they're undecided originally. It's really hard to make a fourth year medical student be like, hey, let alone they have to pick radiology, surgery, medicine, let alone to be like, hey, you got to pick interventional radiology and then we'll see you in 6 years when you're done. And, like, hopefully you still like it, because that's the biggest limitation of the integrated residency is making people decide so early when they really haven't done it.
Do you still have like transitional year or a first year? So you still do the same?
Yeah, that's still the same. There are some integrated IR programs that have folded in the internship so that it is a true categorical program, just like a general surgery program where you come in as an intern and then you leave after 6 years. You do 1 year, whatever you want, or whatever the program sets up. So you can do transitional if your program does not have an internship year attached. My program does not have an internship year attached.
What did you do for your internship?
I did transitional year.
I know.
Same
Where?
here. Yes.
Where did you guys do it?
I did mine at St. Joe's in Chicago, which is in like Lincoln Park, and it was amazing.
Oh, I
I
bet.
still talk to my friends from there.
Quinn?
Yeah, I did mine in Boston at like a combo program that was like 3 or 4 different hospitals, Leahy,
Yeah.
Tufts, all sorts of stuff like that.
I did. My dad is a neuro IR, and he convinced me that I had to do surgery, and so I did surgery for a year. I will say I absolutely loved it, but I was a little jealous of people who had like elective months and things like that.
Yeah, I think the residents that do surgery have a leg up when they first do their IR rotation. So for my residents that go through a surgery internship, they definitely know what they're doing. Usually the residents then kind of get, they eventually catch up to each other. But at first, the patient management skills in surgery are definitely better. So
That's right. I have a few med students that I mentor through the SYR mentoring program, and I've talked them all into surgery, and they'll probably hate me for it, but one day they'll be glad.
Yeah. No, I was the weird guy in my TY year who...
you the weird guy?
You didn't let me finish my sentence there, but good job. Kudos to you. I wanted extra vascular surgery because the guy was really cool.
Yeah.
And he was really fun. And so I ended up like converting some of my medicine months to surgery with this guy. And we just had fun. He wasn't that good though. So I guess it's okay.
Well, then he lets you probably do a lot then.
No, I just had fun. So how many people is in that transition period? Is there a lot of DRs who are like debating to go into ESIR, and is there a lot of like mentorship there, or it's kind of confusing to me?
Yeah. So I could give you some match numbers, but let's just say, so like I said, the ESIR and independent programs, our version of the fellowship now, the independent residency, were set to allow the transition to integrated. So right now, the ESIR and independent 6 years ago, were filling fully because we were in that transition period. Now the integrated programs have filled up, and there's programs that are having 4 or 5 residents per year of IR integrated. So you have basically a large surgery program, And so we're not seeing as much interest in the DR because most of the residents that we are capturing that are interested in IR are going into integrated. So you're seeing actually of the funded positions in last year's match for the independent or our version of the fellowship, only about half filled of the funded positions. And so it's an issue. It always comes down to money and training. Follow the money and you can figure out kind of what the niches are and where people need to be from a funding standpoint. So we want to transition, particularly in my program at UCSD, I want to shrink the independent funding and actually move it all to integrated. But as you can imagine, taking a 1 or 2 year funded physician and then expanding it to 5 years, that creates some logistical hurdles. I think most programs, across the country, we really want it. And I'll shout out to Aaron Fishman. When he was the president of APDIR, he was really dogmatic about this, is that you need to expand your integrated residencies early so that then you have the workforce ready to go and that you're filling the program. And so transitioning away from independent. I haven't been able to do that yet. So I'm up here on my soapbox as the president of APDIR at SIR telling people they should do it, but I haven't been able to figure out that from a funding standpoint myself.
So Quinn, from an interest standpoint, and I know you said follow the money, and things are happening in diagnostic radiology that are unique for that job market. And, I talked to you and I talked to some other people in academics while I was at SIR. Are you guys seeing people transfer out of IR programs into diagnostic?
Yep. That's also, and I think it's a heterogeneous reason, but there are definitely reasons where people see the lifestyle. I would probably rank this number 1 is that people are leaving IR because of the diagnostic lifestyle. You and I, all of us know that diagnostic radiology is very tough and it's very grueling being there on an 8-hour shift doing ER. But people see that you can have flexibility in where you're located, reading from home, not being on site. So there's definitely a drive. And plus, right, the job market is hot. Diagnostic radiologists are getting paid a lot of money, and they do not have to have an on-site presence in order to make that money.
Well, it's crazy. I mean, I have 15 plus independent contractors in my group, and I think like 70% of those people are all IRs. And 2 of those people are my night radiologists, which is crazy.
Yeah, we have a ton of them too. And, one of the most talented interventional radiologists that I've worked with in my first job, I'm not going to say his name, but he was a mentor to me when I first started. And, and I talked to him recently and I was like, how's it going? He's like, I haven't done an IR case in 2 years. I'm like, wow, what happened? And it's like, well, he's like, I got one final complication in a PTC, a tough case. The patient died, and it's like, you know what? Like, I don't need that stress. I don't need that hanging over me. It's like, I'll read diagnostic from my house, make a lot more money and a lot less stress. And I think that is what a lot of these people are saying. I mean, we have lots of independent contractors too. Some actually are doing it as like a side gig when they're doing OBLs. But another thing I wanted to bring up, what's interesting with the trainees that are transferring out of interventional into diagnostic, I think for some of them, some that I've talked to at least, it's that a lot of people go into IR thinking like it's like surgery, but it's easier. And it's like you said, it's a surgical specialty. And I think some people get turned off by the fact that you are going to go in at night. I've done it 3 times this week, and you're either ready for that or you're not.
Yep. I mean, I definitely can say that when I was coming out of med school as well, I was like, I loved IR, and I was like, wow, this sounds like surgery light. I don't need to be as related. So I actually fell victim to that as a med student. Granted, I love what I do, and I can't say, and I wouldn't change anything on where I ended up, but that's definitely went through my head.
But Quinn, one of the things that I wanted to talk about, and something we had talked about at SYR, you and John Spooner-Topoulos and Bill Brown and I, was the change in the ABR boarding process and why that's important and what you think about it. What has changed in how we basically board our residents and fellows?
Yeah, so the ABR, as you guys probably know, I think Sabeen did this. Sabeen, you did the oral exam, right?
No. I was the first class.
You were the first. Okay.
I was the guinea pig, and we were so freaking running like guinea pigs around, not knowing what to do. It was really funny. I mean, that was a funny year. We were just like, oh, they're just testing us, and we didn't know. We had to take our test 4th year. I think most people take it 3rd year now, right? Yeah, I was just a guinea pig.
So you were a guinea pig class. Barraza and I were a year behind you. Yep. And so I think we're the second
We gave
class.
you all the test questions.
Yeah,
answers,
you guys
right?
did. So, right. So
Sorry,
ABR. Yep. Yeah. Right. I'm a volunteer for ABR. I do not endorse that.
That whole ABR like fiasco happened. Like that. Yeah, it just was like crazy. And then and we were using some stuff to study. So whatever. I don't know
well, it's very right. Anytime you change board processing or board certification, right, that's a nerve-wracking time for residents. I mean, the biggest consternation that residents have throughout their residency is prepare for boards, right? So almost all the residency is planned on it. We worry about the workforce. I mean, there's meetings after meetings. So just to give like an overarching view of ABR, so the American Board of Radiology used to have an oral exam. All residents, at the end of your 4th year, you went to Louisville, and then which I think became Tucson/Chicago, and you took an oral exam. You went through all the different types of specialties, all the subspecialties, and you had to come up with a very obscure diagnosis as well. Walk through the kind of the basic ones, but everybody was afraid of it, and it served its function. They then moved to the core exam and then added a certifying exam. So for about 10 years, they were doing the core exam and doing this DR certifying exam afterwards, which was all computer-based. And of course, in 2020 was a big hiccup as well. So then they moved off from being on site. So all of us, we went to Tucson or Chicago and went into a big room and then took our test for our core exam. And then, of course, now you're doing it at home. So the ABR approached, a bunch of the leaders, and they basically said, what do we need to do to make sure that our examination process looks good in the eyes of both the public, but then also other physicians and also radiologists as well. And so they re-added the oral exam back to the diagnostic board
I did not know
certification.
all this. I didn't even know all this.
And
What?
that is coming in the 2028 type class, graduating class. So it's going to be instituted in another 3 years here, 2 or 3 years.
I just heard so many crazy stories about this, and I thought it was really funny. It's in the hotel rooms of the examiner. Like you actually go into the hotel room.
Quinn and I did that for the IR
We
boards.
did it. I did it for the IR part.
But Quinn, your integrated IR residents, they have to take this too?
Yeah, so that was just recently decided about a month ago, is that we, as the IR residents, you graduate, you still have to do your board certification. You're getting an IR and a DR board certification.
that
So we
makes
would take a DR certifying in conjunction usually with our IR orals. So you get everything done usually in a day, sometimes a day and a half. And then you would come out board certified in IR, DR. And this is after your core exam, right? So we're talking sometime either at the end of your training, 3 months out, 15 months away afterwards.
But you could do either. You didn't have to do both.
If you're in an IR integrated program, you generally had to do both together. Most of us suggested that you do it, but you could be board certified. If you did an IR program, you could just sit for the DR certifying exam and not sit for the IR. If you sit for the IR, you have to sit for the DR. So there's no just IR board certification. It's either DR or IR-DR, if that makes sense. Short story is that the ABR went around and also got a bunch of advice and collected opinions from everybody else in regards to what to do for the IR residents now that the DR orals is back. And they said, as a month ago, well, IR residents, now you're going to both do a DR oral and an IR oral. So
I thought the IR oral was kind of fun.
Have to do both if you're IR, DR certified.
So I had a big argument in mind that I was going to lay on you guys, and it has changed. I didn't realize you didn't have a choice.
We do not have a choice. We've been told by the ABR that we need to start preparing for this. The timing is not set up yet. So I do sit on a committee for that, but we're basically figuring out when do you take it. So in our IR integrated residency, we have the core exam still at the end of the third year, just like the diagnostic residents, your PGY4, your R3 year, which is going to stay. That's not moving. That's not changing. And we're talking about the first time you get to take it. You actually have 6 years after you graduate to get board certified. So you could take board certification like in your fifth year.
After. I'm sorry. I took my IR oral certification. It was like a year and a half after I was in practice, and it was fun. It was like easier than it would have been if I was in training.
Yeah. And that's the intention. They want to make it so that it's walking around knowledge. This isn't obscure. They want to make it so you're a safe practitioner and that you know what you're talking about. That's really the point.
So what do you think about this? About the change in the board process and the fact that you have to take both?
I'll give you two things and I'll give you my answer. So one side, right, is that we're IR and DR board certified, so we need to be both proficient in DR and IR. So I understand that thing. I also understand where a majority of us are IR physicians, so I don't really have DR skills anymore. It'd be really difficult for me to probably pass a DR exam at this point without studying extensively for it, so that adds time. I personally didn't like that they had to add a second oral exam. I thought that just a computer-based DR exam was fine for us and to do an IR oral, but it's here. Most of our residents, I think, do really well with taking an oral exam. We have them prep for it. We give oral board examinations throughout the year for our residents, so they're ready to go. We never went away. So I think the IR residents are ready to go from that, but it's just going to be having to relearn peds, having to relearn breast if you've been stepped out of that for a little bit of a while. Those are tough things. So yeah, it's just more things put on an IR resident, but the ABR will say, we are board certified. We're getting our board certification in IR and DR. And as you see with the job market right now, it's driving the job market. So we all want our DR board certification.
I think it's something nice to have. Who knows what happens, to our backs and stuff in 15 years. But then you have AI. So I don't think DR is going to exist. So it's okay.
I just think that, though, at this same time, we have to be realistic of what the average job is out there. We've got Quinn in academics. We've got Sabeen. I would call what you're in private-demics. Why don't you tell us about your job, Sabeen?
Mine's a private group. I joined 10 years ago. It's a, physician-owned private practice that contracts with a hospital, one hospital system. And we're your traditional like mom and pop IR DR practice. Like it's just, there's no C-suite. There's nothing like that. It's run by partnership track which is now 11 people, and then people who are rising partners. And it's a very heavy clinical IR practice. And it was built that way, fortunately, to, be able to do vascular, stroke, and everything just like yours, Mike, with a lot of things that I didn't train in. So that was cool. But what's funny is I always thought I was immune to the DR drama. And what's funny is we still are. Like, we don't have DR and IR hate at all. Like, it's kind of funny, but we have a lot of drama going on with the DRs between themselves. And so it's really funny how things are changing. And, then I start telling you, like, I saw Quinn at the airport at the end of SIR, and he's telling me like 7 other groups, like, 4 other groups that are just, having a lot of issues. And so, this will be a good leeway, after, this. And Mike, when you describe your practice, is what does the job market look like after this? But Mike, like, so that's my practice. It's something maybe eventually, and, I probably shouldn't say this on the record, but I want to be IR only. So,
well, I think most of us do, Sabeen, right? That's what we love. And that's what the integrated residency was set up for, is to direct residents to practices like ourselves. Academics, where you're doing 100% IR, go into a big private practice group or even a small one that is all IR, very heavily clinical focused. The issue with our training right now is that we are getting good training for DR, but the job market still demands an IR-DR hybrid, particularly in rural areas where that's a very valuable position. And really, we don't have training that's really set up for that, as you can probably guess.
I am not even in a rural area. I'm in, Baton Rouge, Louisiana. I'm at the largest hospital in the state. And
Louisiana?
Love Baton Rouge.
Wait, Louisiana? Is that not rural? Where is that on the map? I just know California.
Quinn came down for an LSU game last year, and I highly recommend doing the same. Both should come.
The red carpet was rolled out by the Barrazas. It was quite the time. And we even got matching boots together. So,
So my first job was, a huge group, IRDR, and I hated my job. I'd go every day and I'd have whatever was on the board, whatever was ordered, and it would be, some biopsies, some basic stuff. And I was really lucky, like a Y90 or whatever I was able to dig up on my own. So I left the practice, and I remember a guy in that group, and I told him I was leaving, and he's like, I assume you're going to 100% IR practice. He's like, that seems like what you want. And I was like, actually, no, like, it was during COVID. It was time to move. And I joined a practice that is, it's also a traditional IR-DR group, where we only have 4 interventional radiologists and like maybe 30 or 40 diagnostic radiologists and an army of PAs. And I was worried when I got there. It's like, it's going to be a problem doing as much diagnostics as they do there. And the deal that they made me was like, look, like, you're going to have some diagnostic days, but you can book cases. If you book outpatient cases, you can book them on your diagnostic days, fill your entire schedule for all we care. But, you're in charge of that. I have found that, like, after a week like this, like, I relish having, a short diagnostic shift every now and then. And just to give you an idea of like what a private practice day is like today, I got up, I went to the tumor board, hepatobiliary tumor board. While I was at the tumor board, I got called over for a carotid blowout. And so I went over and did the carotid blowout, embolized that.
Where was my call? You used to call me for these.
I know, I did.
Now you're too good.
I remember the first one of those I did, I called Sabeen. I was like, can I stent this? Like, sure. And then I went over, I had a Y90 mapping, and I had a TACE, and I had 2 clinic patients. Then the hepatobiliary surgeon called me. He's like, hey, I did a Whipple, and I reconstructed the portal vein. This thing has gone down. Can you stent this? And I looked at it, and it's like, I don't think so, but I'll try it. And so I did that, and it went great. Stent the portal vein. Then a GI bleed. While I'm in the GI bleed, someone calls for a stroke. I had to do a stroke. In the middle of all of that, I read 80 diagnostic studies.
80?
Yeah.
No, dude.
Yeah.
Okay,
Yeah.
Mike, you take the. I was gonna say like, well,
That
this
is
is
not-
a busy day.
That's
crazy.
That's not an average day. That's not an average day.
No.
It
That's
was a very
insane.
busy day, but
80?
it just shows
How'd you
you
do 80 in that? I'd still be like working on the GI bleed. Like,
I didn't finish on time. But the point is there's a lot of variety in my day, and it's a combination. I do real clinical IR. In the middle of that, I rounded on a patient from the day before. I had clinic patients, and I've got a real longitudinal clinic with a clinic nurse who works 5 days a week. But it's a slog, man. I do a lot of diagnostic radiology. I don't hate it, and I did when I started. But it's one of the differences in my old practice and my new one is in my last practice, I did very little real IR. Now I do more high-end IR in one day than I did in a couple weeks there, and you do a whole day of that, it can be exhausting. And sometimes I like having, 6-hour diagnostic shift from my house. I felt guilty about it at first. And that's the job. And I think in reality, I think a lot of the jobs out there require that.
Well, I mean, to our listeners, one thing I have to say is like Barraza is a beast. Every time he tells me, and he has like a neuro guy who has to retire, and he's doing all the neuro in his practice. Like he's a crazy beast. So
One of one, this guy.
yeah, it's not the norm, but I do think what Mike is saying happens to a lot of practices. In my practice, I do a lot of high level stuff too. And Quinn, like, what do you do? What do you actively do for your residents and your training? And then generally, what are people doing to be able to prepare for cases that they haven't trained on?
That is a great question.
Thank you.
Yeah, thank you. You've done this before. I do harp on residents all the time is that really every case, no matter how basic, like say you're doing a dialysis case, it's catheter, it's wire work, right? So that's number one, is getting the skills and having repetition when it comes to any endovascular procedures. And then you're able to usually extrapolate that into things that you haven't done before, and that's principles. So number one is teaching the principles and having volume. So if you're in a residency where the principles are taught, you're in an educated area, you're given autonomy, and you're getting the principles for your practice, and you're getting the volume, you're going to do well. And we all know, you see a resident, and generally the residents that just get it and it clicks and that they can MacGyver stuff on their feet, that is generally what's always separates a good trainee from a great trainee in my eyes. Is the good trainees can follow the algorithm and do the things that they need to do. The trainees that can get thrown anything, and also attendings as well, just like, and I did fellowship with Barraza, so I saw him do all this stuff that he's about to do, or at least the foundation of it. And so, and you have to have it. You just have to have the skill, and it's something that's innate, I think, as part as well, but also there's an educational component. And so for me, I try to give as much autonomy as I can when I work with residents. I try to let them make mistakes. I try to teach them on where their mistakes are and where they can get better and where they should be more efficient. It's generally efficiency. Ignore the blah, 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 ignore the fluff, and then be down to the brass tactics on what you're really doing. Hey, what is my goal of this case, right? So if you're getting in and you're like, I'm not sure if I'm going to even ablate this case, or right now, like, okay, you've already killed it with TACE and you're going to go for the TACE ablate. Should you even really be ablating? Like, are you going to spend 2 hours in there trying to get the probe in the right place if you've already killed 99% of it? So bring them back and live to fight another day,
So I thought it was pretty cool, a story you told me when we were at SYR, talking about your teaching style, something that I didn't have a lot of when I was in training. You were just talking about a splenic artery embolization, and you had your trainee get in there, get access, and get out to the splenic artery. It's like, what do you want to use to embolize? I don't think I'd ever been asked that before.
That's cool. Yeah.
Yeah. I mean, and I think that comes, and they let them work through it. I'll have my suggestion for sure. They may say they want to put an Amplatz or 4 in there, and I'm like, well, you're not going to be able to get a big old, 6 French sheath or a 5 French catheter out there, but you could do an MVP if you use a microcatheter. So yeah, I mean, it changes your brain. And I think there's a lot of longevity for physicians out there when they go into private practice and then they move back into academics. Sometimes it helps them with the longevity of their career. It changes it up, allows you to do things differently. So there's all sorts of different types of physicians for a reason they go back in academics. And then there's a bunch that believe, right? Because that's not what they enjoy. I enjoy teaching, and it fulfills me from a day-to-day. So academics is probably where I'm going to stay. I do go do locums, and I find myself being like, I'm doing this cool case, and I have all these teaching points, and I'm looking at the tech in Montana, and I'm like,
Quinn, that's when you call me. That's when you call me, Barraza, look at this. Let me show you something.
I mean, I have two comments. So I don't have trainees, but I have, people that I've hired and worked with and try to
And
teach
hold their hand.
and hold their hand. But one thing that I noticed is, and this is to trainees out there and early career physicians, is that I think being teachable is a characteristic that like is taken for granted. Like someone might come and be like, they know what they know, and like they're not going to really listen to what you can teach and do. And I think being teachable and amenable to like criticism and seeing how you can do things differently can really help you grow. Another example is like when I came, I was a Northwestern lifer, right? I went from undergrad, residency, fellowship. I came to my practice. I thought the way how I did a port was the right way to do it. And I was like, and then they were showing me how I was doing it. They didn't like it. And I kind of felt like, a little butthurt. And now I realize I changed the way that I do it now. Like you have to have that open-mindedness, which I've seen through my practice. Some people don't, and that really hurts you.
I'd say the having two different trainings as well. So Barraza and I are both combinations of two different right? So you did a residency once somewhere, like Barraza did at Vanderbilt. I did mine at UCSD, and then we both went to Penn. So you see different ways to do it. And that actually, and we were talking about ESIR earlier, so that's actually one of the reasons that some residents choose to do ESIR. Like one of your partners, Ray, so I mean, he chose to leave UCSD and go to Northwestern and not stay for the whole time because he said, I want to see how other people do it. I know how you do it, but I want to see how other people do it.
I loved seeing how people do things differently.
My first time seeing that was going to a practice, right? But I was so in my bubble and a little bit of the Northwestern culture is that the way we do it is the right way, right? So it was very eye-opening for me. But then I realized, and I see it with other people, I'm like, if you're teachable and you're amenable to like learn different things from other people, like that'll take you so far in your career. It took me really far once I got over that. And now, like, I mean, it's just crazy. And then I see people who don't do that and they didn't go so far.
I want to take this in a different direction for just a second, but back to the trainees. Like for me, in my first job, going from a very clinical place, Penn, into a place where I thought I was going to have all the time I wanted to round, to have clinic, to do everything I wanted to do as a clinical IR, and not give a shit about diagnostic radiology, which I did not give a shit about. It was a rude awakening. I'll never forget. I did this peripheral arterial case that I actually asked you for advice on, Sabeen. It was the first time I'd ever really done like bilateral iliac occlusions. And I did this unbelievable job. I was so proud of it. And it took
I probably gave you bad advice.
No, I asked you and Kumar, and it took me like 5 hours. And it was gorgeous. Like one of the most beautiful cases I've ever done. I get out of there, and the diagnostic radiologist at the hospital that came and just like basically said like, hey, I left all of your diagnostic work for you. Thanks a lot for all your hard work. And I was like, this is the worst thing that I've ever done. I was so pissed. It's like, this is awful. And that was something that I was not prepared for at all. And then even when I took my second job, it was something I had to get used to, like having like responsibilities other than patient care, and I remember somebody making a comment like, Barraza is doing a really good job. It'd be better if he would sit in his chair and actually read.
Oof. That someone said that?
It was early on. It's like, and I'm a big tumor board attendee, and everybody in my practice does that, but I had to get used to the balance, to be able to reconcile both. So it took me a couple years to figure out how to practice high quality clinical IR and practice the patient care that I was trained to do and that I enjoy doing, but also meet the responsibilities in my practice. And it was a rude awakening for me. And I'm wondering how people are preparing trainees for this, because I think a lot of them are going to get blindsided like I did.
Are trainees going to IR/DR practices?
Yes.
Is it?
Absolutely. I mean, how many? There are some great IR-only private practice jobs out there, but there aren't a lot of them.
I mean, I think, we're at an inflection point, and I mean, you see it in chat rooms and you hear where people are with our groups. And so the diagnostic and IR partnership is very difficult to maintain currently because diagnostics revenue is going way up. It's very difficult for people to maintain diagnostic radiologists within a hospital system because they could just leave and go somewhere else and work for more money. And that is a really difficult thing. So IR groups are being kind of left to negotiate with hospitals on their own. And this is what Sabeen was alluding to earlier. We're just talking to 4 or 5 different friends all over the country, and they're basically having to set up their own hospital contracts, right? And say, hey, we're IR, we'll provide. There's no more diagnostics on site. So what's it worth it to you for our services? We can, do urology, GI, we can do vascular, we can sometimes do stroke. And then in addition, all the usual stuff that, generally falls under the IR. So it's a wild time right now in order to be a group, right? You could, just like when host Ali did the podcast about the OBL ASC hospital payment system, that stuff is there. And so groups are having to choose where they're going to go. Are you going to just stay in bed with the hospital system and really provide high level care and get a good stipend and elevate your salaries to be on par with the diagnostic colleagues? So there's so many different ways to go about this, and who knows what's right. Personally, I would want to have an on-site presence. That's just where I see this going. It's a little bit short-sighted from my perspective if you're a DR group where you're alleviating an on-site presence, but the job market's there, and if I was in their shoes, I would want to be telly in my boxers as well. I mean, I love doing a little
I like to do that some, but one thing I grappled with after my first job was like, these OBL jobs. Like I really looked hard on them, and now, we have all these like prostate heavy or, embroid heavy or, GAE heavy OBLs, and they sound really cool. And I think now, like if I was leaving my first job and that had been available, I probably would have jumped and done that. But I think, for trainees coming right out, I think there's some danger there in jumping right into that for a couple reasons. One, like if it's not already funded, like taking on that financial risk, that was something I wasn't wanting to do. But two, like I absolutely love hospital inpatient IR, like trauma, strokes, biliary drains, like whatever. Right? I would hate to pigeonhole myself into just being like I'm the GAE guy, like 1 year out of practice, and then like it didn't work out. Like trying to go to like, hey, when's the last time you did a non-dilated nephrostomy tube? Like
I would 100% agree with. That's the advice I give: is you got to go to a group that's doing it. I mean, it's good to have that, but Sabeen and I have a mutual friend who works in LA, and he just moved out. He left his group and his hospital-based IR practice, and he's now doing prostate arteries with a partner. And so this is like something where people are doing, but he's 10, 15 years out of practice. So that's appropriate, I think, for him. But if not as a first year, not within your first couple of years, it's just tough. I mean, there's people that are doing it well all over the country, I'm sure, but it is one of these things you kind of, from a training aspect, you want to get a lot of variety. And I think most people agree with you, Mike, is that most of us love to do the trauma stuff. What beats you down is when you're doing a complex trauma and somebody walks in your room and demands an LP, and you're like, what?
We got PAs, but like my soapbox is, when people talk about like trash collecting IR and like, like you're not doing exactly what you want to do 100% of the time. Like the services that you provide in inpatient IR are vital services that make a major impact in patient care and can sometimes be the most rewarding things you do. And it's not always going to be glamorous. And I just like, I really resent the sentiment that like when you're providing patient care to somebody, if it's not like the specific favorite case that you have and it doesn't reimburse like 30 RVUs, that it's not like, it doesn't have value.
I was called in last night for a placenta accreta case. So
those
they
are
usually
great.
have this. Yeah.
I've never even done one.
They're always in the middle of the night.
They're always
UCSD. Geez, we don't get this in the community.
There's an algorithm here, and like Ann Roberts and Zach Berman and one of our trainees, Christine, doing all kind of set this up, and so it's there, right? Of course. So they call you in and they love your opinion and you're very valuable, and you do an embolization right before they take out the baby and figure out if they can save the uterus or not. But that's right when they call you in. Family discussions, you're up there for 3-4 hours, not in the the UAE part is like 15 minutes.
15 minutes. That actually, I was talking to a med student at SIR. He was like, what do you get called in for at night? Like, how often do you get called in? And it's like, well, most of the time I don't get called in at night. Like I might have a stroke, but strokes for the most part, unless they're transfers, are going to be before midnight. Level 1 trauma, that could get me. The wild card is a peripartum hemorrhage. They can be brutal. They do move fast, but like they're very rewarding.
they're pretty stressed on those cases.
They are very stressed. They're about trauma level stress. Trauma
Beyond,
surgeon stress and OB guide stress are high.
Community OB is really stressed.
So, and I find, those patients are young generally on the younger end. And so you save when you do it and you find the bleed or you fix the postpartum hemorrhage, you save their life. So
you might save 3 lives, honestly.
Yeah.
They have kids again, and those are some of the happiest patients I've had. I bitch about it when it happens,
and that's the one thing I think for trainees. And so whenever I have a trainee who sits down and says, I'm thinking about coming from DR to IR or going from DR to IR, I say, is the patient care something you cannot live without? If you need patient care, and I'm being obviously broad with patient care, but I mean clinical face-to-face interaction with a patient and you being their doctor, and that's something you need, then that tells you that you should be an IR. Because otherwise, if you don't need that and that is no value, if that doesn't fulfill you, then yeah, I'd probably tell you to go towards DR because you can do, your lifestyle's better and you can make obviously more money in this market currently by doing that.
Where do you see the job market changing now? I honestly see the job market extremely volatile right now. At our times when we graduated, all of us, there's IR, DR, there's IR, there's OBLs, there's academics. I mean, what do you think things look like in the next 2 and 5 years?
2 and 5 years. So I think that all politics is local. And that is one issue I've had with, most arguments that IR and DR have to switch. Nobody is going to tell my individual practice what to do. However, I think that in 5 years, I think we are going to see nationwide, most practices are going to be splitting off. IR and DR are going to be going separate. The reason being is some of it is revenue related. That what I bring in a given day, if I'm doing IR and DR, I'll be honest with you, but what I bring in is I probably produce on average as close to the top of my practice in terms of productivity because of the combination of IR and DR. But that is not normal. And you get all this pressure for these DR guys like, you're subsidizing your practice, whatever. But you're also seeing these diagnostic guys that are getting farther and farther away from patient care. They're not doing fluoro work. They're not doing procedures. They're just doing diagnostic work only. IR is the face of most practices. I just think in the near future, people are going to get sick of it and we're going to split off. That is my guess. I don't think it's going to be everywhere. That's why I say politics is local. I think in my practice, it's not happening anytime soon. But I see the practices, like the hospital contracts my group has taken. My group will provide radiology services for a hospital and just say like, hey, you guys figure out your own IR stuff. And they're hiring people independently. I just think that my personal belief is that it's going to be a split.
I mean, Quinn, what are you seeing like in your trainees? Like, no, it was good. And I have some comments.
Sabeen, I'm actually interested in your 2 and 5 year outlooks as well.
2 years, milk it.
Yeah, 2 years, milk it. I don't know. If you asked me this question 6 months ago, my answer would be different. But I really do think that the IR-DR split is happening way more faster than we think. What you're talking about, Mike, and what I used to believe was the DR subsidizing IR. But now, if you look financially, the DR RVU does not equal the IR RVU. And if we want to get into finances, you can talk about like $80 an RVU for a DR versus 140 RVUs at IR. And things change. I know these numbers are crazy.
They are crazy, Sabeen.
Yeah, I know. I'm pretty crazy, right? But what I'm saying is there's a shift as far as like what IR is doing, what DR is doing. And I think in 5 years, I don't think there's going to be an IR-DR group out there.
Non-academic, you mean? I mean, academic, it's going to be tougher. Yeah.
I disagree. I mean, I think mine will still be doing the same thing in 5 years, but I'm in a very unique practice.
I also think AI has a big influence in DR and eventually IR too. But the initial feeling is with it, and I'm a tech like guy, right? So I'm like rooting for AI. So I don't know. I don't know what the effect of AI is going to be when hospitals, there's so many hospitals out there that are like screaming for DR help. And when things change, it's going to change real fast.
I mean, and we've already seen a microcosm with APPs, right? So a lot of hospitals have screamed, we need somebody to do the basic procedures that don't pay anything, the paras, the thoras, the LPs. And when I say not paying anything, I'm talking about pro fees in hospital. But, so these that nobody wants to do. And so PAs and MPs have kind of filled this gap because, right, they're theoretically cheaper labor into the hospital system. They do require, but right. And so that was a fundamental switch to move it. And whoever they're underneath, if they're under DR or IR or the hospital system or an internal medicine department, right, this is begun. So that is a kind of a microcosm of where I see where is the work being pushed and facilitated. And yeah, I mean, it's just two different worlds. And I don't see, I'm with you guys year 2 and year 5 as well, where there's just, some like Barraza's practice will probably stay together for that period of time. I foresee, particularly in San Diego, what I'm seeing is like, people are headed apart.
You guys have had so much change in San Diego. I know all of your private practices there there's been so much change in the last 2 years, and that's not even after everything is like, there's so much going on.
I want to talk about APPs, but I'm scared it's too controversial about what they're doing in my practice.
This is a controversial episode. I just said that.
It's a controversial podcast.
I just said DR is dead with AI. So I mean, if people could understand that like innuendo on the audio, then
my group
then
has 3 times more interventional PAs than interventional radiologists.
Wow, you're like Mark Lesney's group that has like a ton of APPs.
Yeah. Yes, actually, it's quite similar, but they do all kinds of, they're so talented. They're all PAs. They do all the paras, all the thoras. We have the PIC contract. They do all the PICs. They do all of the diagnostic fluoro, the upper GIs, esophagograms, et cetera. They do the lumbar punctures. They do the joint aspirations, the joint injections. They do the ports. They do the tunnel internal jugular catheters. They even do arm ports. They do, I said paras and thoras. They do
bone marrow biopsies.
They do all the bone marrow biopsies. They do thyroid biopsies. They do any kind of ultrasound biopsies, thyroids, lymph nodes, parotids, but they also do CT guided cases. They do CT guided biopsies. They do CT guided drains. They do all kinds of stuff. And quite frankly, they're so good at them. And I'm sure I'm missing a lot of the stuff that they do. I'm missing a lot of stuff they do. And the argument, frankly, this is the part I might want to cut out, is that
it's fine.
Like it frees the interventional radiologist up to do the high volume cases. I can do my embolization. I could be on the list. I can be reading.
It's the whole reason. No, there's no wrong thing about that.
UCSD has done it too. There's 9 APPs currently.
Tube changes too. All the tube changes.
Quinn, so just another question about that. I mean, the challenge we have is my hospital won't grant my APPs sedation privileges. Do you have that problem? Or is that can be local, which I think it is?
Yeah, I don't think so. And I don't want to speak out of turn because I don't do the supervision and the credentialing for the APPs, but I believe it's still under us as being close and within the room, but they can do the sedation. They're there for the timeout. We do not need to be there currently for the timeout, from my understanding. But California, Mike, is one of the big issues of California is that this fluoroscopy license, right? And that has limited NPs from getting it and made it very challenging for PAs to get it in certain places. So UCSD has kind of figured out a way to get the PAs the certification, but it's very difficult outside of that, right? And so they kind of led the way.
My PA figured it out and created a whole program, a fluoro school, and maybe that's going to be a separate BackTable podcast. You just gave me that idea.
I've already got one lined up with a PA to do that. We'll do it together.
Another 2 hosts, 1 guest.
Quinn, I thought about you actually yesterday. I did a spleen and I was like, Quinn told me that I could put a coil down and do Obsidio after.
Yeah.
I didn't do it. I just coiled it.
Your GDA? Yeah.
GDA for sure. I just did a renal on Friday.
I had a GDA today and I wanted to do it. I really did.
I think the biggest thing with us is really maintaining and supporting and knowing the difference of practices. And so, you hear everybody talk about how it should be done. There's people that are very vocal about just everybody get rid of DR. I think most of us see the writing on the wall, just the three of us here, is that, yeah, there's a separation coming. When does the separation occur? How does it look like? Are we financially stable as IR only and depending on your practice? So, but in reality, right, the biggest thing that I teach to trainees, and I tell anybody that's thinking about IR, is that IR is a surgical subspecialty and diagnostics is a little bit more shift work related, right? So you're similar more to your ER doctors and your anesthesiologists when it comes to the shift work, right? You leave that day and you hand off your work, where IR is, it never ends. So, and that's the biggest thing, is figuring out groups, practices in via healthcare economics to put our trainees. And so the ABR has said, and what they're doing, the DR oral and an IR oral, and requiring that for our trainees, is they're saying that, yeah, there's groups out there that are going to require IR and DR. As you can probably guess, we might not be there and soon. So this may change in 10 years.
I believe right now it's the right thing to do.
Yeah,
It's like,
me too.
You can do both and you can do it well.
Well, people can, even if you join an IR only group, you can supplement a lot of income with your DR. And then you have this backstop if you get tired or you want to retire at 60 and you still want to do DR. I mean, we're in a very lucky kind of situation in our medical field. And one thing I'll also recommend to all of our listeners is that reach out to us. There's so much of a network, with Quinn. I mean, you go to SYR and you just see everyone know each other, right? The network, and I feel like all IRs cheerlead for each other. I have friends in different specialties, and they're like, "Why you guys all support each other?" They're so confused. I'm like, yeah, I want Mike, I want Quinn to succeed, and that's why on BackTable we wanted you to come on, and it's a different culture than other practices like plastic surgery or dermatology, where everyone's just trying to get their own brand alive. But for us, I think we try to support each other's brand because it's IR. And so just tap into that network because we're all down for it.
I think you talk to any rep as well and anybody outside, right? So the people that interact with multiple specialties, you talk to somebody who does endovascular work, they generally say that they like to work with IRs over VS and IC, not necessarily because of, we all have differences in personality, but I think that's our strength, is we're collaborative, we are friends, we do really well with our cheerleading, like you said. And so, yeah, I mean, the community is great, and I'm glad we all chose it. So, and this is part of it as well. We just got to figure out the economics.
You get to be the hero a lot.
Well, I think it's probably a good time to wrap it up. Quinn. I know. Quinn, it's pretty cool to get to know you locally, and thank you for being a part of this. I really wanted you to come onto the podcast, and having Mike and you, it's just a great community to be a part of. So, Quinn, thanks for taking the time. I mean, Mike, this is my first time doing a guest host with you, or not guest host, but a co-host, and I want to do more. So
yeah, we gotta do it again. Talk about whatever you want.
I really appreciate you guys' friendship as well, and you guys did an incredible job with the BackTable. So keep up the good work, and I can't wait to when we go to the next LSU football game with Barraza.
Sure.
And I forced you to come with me. So Bonnie, if you're listening to this, I'm putting Sabeen in my suitcase.
She doesn't listen. Yeah. I'll get tickets.
Keep pumping out good residents. We'll hire them. So
yeah.
All right.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabeen Dhand,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.